Good evening. And is that working in terms of, can you hear me at the back? Right. It's hard to tell from here. Welcome to this evening's Adult Social Care, Health and Communities Overview and Scrutiny Committee. Can I ask our Democratic Services Officer, who should be congratulated on getting the temperature of the room to what it is, to tell us if we have any apologies?
Thank you, Chair. We do not. There are none reported. Thank you.
Excellent. Can I ask whether members of the committee have any declarations of interest to make? Okay. So we'll go on to item 3, which is the minutes of our last meeting, which took place on the 23rd of April. For those of us who were there, are they a correct record of that meeting? I think they're pretty masterful set of minutes. So well done, Richard. Thank you very much indeed. So we approve those as a correct record. So I come to Chair's announcements. Can I welcome I think we have 3 new official members of the committee. So Councillors Petter, Owens and Shahan, I think, has formally joined us, although I think you came as a substitute for the last meeting. So welcome to the meeting. We cover a huge area, so you'll gradually catch up with what we're trying to do. The meeting is being webcast, so we need to use our microphones and speak clearly so that those at home can hear us. We don't have a fire drill planned, so Richard will sort us out we'll do what he tells us. Could you make sure that your phones and laptops are switched to the silent mode? And we're trying to be disciplined in terms of, well, 2 bits of discipline. One is we've got quite a big agenda, so we need to keep to time for our various items. I'm working on the basis we spend half an hour on each item. That's the plan. But also we try not to raise sort of individual casework at the meeting. That's to be dealt with elsewhere. Our aim is to scrutinise and policy and overview. So that's our aim. And yes, so those are my announcements. Be useful just to go round. We don't have nameplates, so it might be useful if we went round and introduced our members of the committee, and then on each item we'll get officers to introduce themselves for that particular item. But just so that we introduce the committee, so I'm Bob Purser. I chair the adult this scrutiny committee.
Hello everybody, my name's Hayley Adkins. I am the Vice Chair of this committee, also Chair of the Children's Scrutiny Committee.
Thank you, Chair. Richard Woods, Democratic Services.
Working? Yeah, I did. Warm up.
No.
Yeah, well, Andrew Simpson, Dawson Quick,
Alison Eastwood, Rural Staff, Ward Councillor.
I'm Kendra Chahan, East Hunsbury, West Hunsbury and Coventry Hunsbury Ward Councillor.
Hi, Artie Kamari, the Public Health Officer for Suicide Prevention.
Claudia Slabon, Mental Health Programme Manager for the MHLDA Collaborative.
Tim McGregor, Public Health Principal at West Northamptonshire Council.
Councillor Scott Packer, Talavera Ward.
yeah, Councillor James Petter. It's Farcott and Briar Hill and Delapre.
Sorry. Anthony Owens, Councillor for Farcott and Delapre and Briar Hill as well.
Yep. Councillor Susan Gaskell, Ward Councillor for Moulton.
Adrian Cartwright, Councillor for the Headlands.
Maria Laffin, Chief Nurse, Leicestershire, Rutland and Northamptonshire ICB.
David Johns, Director of Public Health, West Northamptonshire.
Excellent. Right, that's introductions done. So we're all welcome. Oh, sorry, Rosie, just...
Councillor for Middleton Cheney Ward in the South.
Excellent. So the first item we're going to address tonight is the Northamptonshire Draft Suicide Prevention Strategy, which I think is a really, I know we've had interest in this coming forward to committee, and a really important piece of work, and given that every life is precious, can we ask you to introduce it, Dave, the report, David, and we'll...
Yeah, I'll do a little bit of an introduction and then hand over to colleagues to run through the bulk of this. Just start with a slide that was used at many of our workshop events when discussing the strategy and developing the strategy, which is, I think, important, as much important here as it was in some of those discussions. It is just important to recognise it is a sensitive subject. Suicide affects individuals, families, communities, and some people here in this room may have been personally affected. I know it's the default approach for this room, but it can never go without saying that this subject matter is important. We discuss with care, respect, and compassion throughout. And at the same time, being really clear that today's discussion is about a public health conversation about that population level approach to how we tackle and look at suicide prevention. So whilst the strategy has been shaped by the learning from people with lived experience, and we'll see an example in the slides in a minute, this forum is not discussing individual cases or specific circumstances, it's focusing on that whole population level. Just thought that was useful for us to sort of ground some of our discussion. So just turning then to the background, and this is the sort of only slide I'll do before I hand over to those that have done the bulk of the work and should rightly get the praise for what is a really good strategy, is that obviously we're here to discuss the Northamptonshire Suicide Prevention Strategy, and I think the key part that I'd want to emphasise is that it is a whole Northamptonshire strategy. So it is a county-wide strategy with a single overarching framework, but it's going to have two place-based action plans, one for West Northamptonshire and one for North Northamptonshire. So as such, it's a system-wide effort developed together as a partnership, but also that will need to be delivered together as a partnership as well. And I've mentioned it before, but the strategy has been shaped not just by sort of data and evidence, but also by those with lived experience. And I think that's a real strength of the study, of the strategy and the development approach that has been taken by Artie and colleagues. And I think it's a real something to be proud of in a way that we should approach more of our strategies and will do in the future in public health. So I'm not going to sort of speak for any longer because you've had a chance to review the strategy. Artie's got some slides which I will pass us through when she tells me to move us on. We will cover sort of a recap, some of the sort of key messages within the strategy for you.
Thank you, David. Can everybody hear me okay? So just to give a little bit of the background of the previous strategies, I wanted to share some highlights. So the previous strategy came to an end in December 2025, and there's quite a bit that I think we're quite proud of. That image there is actually taken from the Northamptonshire Male Suicide Prevention Campaign that was launched last year in September for World Suicide Prevention Day, and that's something we continue to share. We developed a support package for call handler teams across Northamptonshire. We are currently still delivering funded mental health and suicide prevention training across Northamptonshire. We continue to receive data from the Coroner's Office regarding real-time suspected suicides. We delivered a suicide prevention protected learning time for primary care with over 1,000 individuals in attendance. And actually from that, there was an action taken to develop a general practice suicide and self-harm prevention and suicide bereavement resource pack, which we've just launched this month, which is very exciting. We also developed a post-vention support package for educational establishments, which is in reference to any educational establishment that might have a suspected suicide, whether that's an adult or a young person, and that was developed in the previous strategy. And we continue to, but up until 2025, we were hosting Zero Suicide Alliance sessions. So these are suicide awareness sessions for anyone across Northamptonshire to attend. And by the end of December 2025, we had almost 500 people attend a session, and we run them bi-monthly. Thank you, David. Next slide. We did invite an individual with lived experience to be here today, but they weren't able to attend. But this is just a quote from an individual called Julian. Julian took part in our Northamptonshire Male Suicide Prevention campaign, but he's also been a member of the Northamptonshire Suicide Prevention Steering Group for quite a while, and is a mental health first aider, and he has lived experience in suicide. And he's just shared that being part of the suicide prevention strategy and campaign allowed him to use his lived experience in a meaningful and constructive way, and it reinforced how vital it is that real voices help shape our approach, ensuring the support we develop is compassionate, relevant and truly effective. My lived experience has become part of something bigger, helping shape a campaign that brings hope to others and being able to normalise conversations around suicide that will help others in finding support. So in terms of how we developed the new strategy, we held county-wide workshops at the end of last year. We did 4 county-wide workshops and we covered 2 priorities per workshop. This is something that was done joint with North Northamptonshire Council. We had multi-agency partners in attendance and we had individuals lived experience. Across all the workshops, we had over 50 people attend. Once those workshops had ended, we then moved into a written consultation period, which was a full 6 weeks, and all were invited to contribute whether they could attend the workshops or not. During this time period, we also consulted with our children and young people. The strategy is all age, so we wanted to make sure that we had the voice of our young people within that. So we attended youth council meetings in both the north and the west and engaged with a total of 22 youth councillors, and we developed and shared a questionnaire with our Healthy Schools team to be shared across schools and other educational establishments. In terms of our vision statement, so we have a new strategy that's 5 years. So we're looking at 2026 to 2031, and the vision for the new strategy is a Northamptonshire where fewer people lose their lives to suicide, achieved through strong collaboration, understanding local needs, providing inclusive and accessible support that promotes positive mental health, recovery and hope. So as I mentioned, it's a 5-year timescale that we're looking at going forward for the new strategy, and we're actually going to be delivering this in phases. We are now currently in phase 1. Phase 1 is April 2026 to October 2027, so looking at 18 months for each phase. Phase 2 is December 2027 to June 2028, and phase 3 will be August 2028 to March 2031. There is a month period in between each phases, and that is what we're calling a review month. It gives us an opportunity to look at what we set out to achieve in that first phase and whether we actually achieve that or not. What's the RAG rating on it, and if we weren't able to achieve it, what are the lessons learned and what do we need to amend going forward or change going forward? And I think that's a really important time for us to really have a moment to reflect on the strategy, and we'll also be sharing that with our steering group and of course through governance as well. As David mentioned, what we're moving forward with is 1 public county-wide strategy, but we're having 2 place-based action plans, which is different to what we had before. In our previous strategy, we had 1 county-wide strategy and 1 action plan. And the place-based action plan just allows us to look at our local need across West Northamptonshire and adapt according to the population. Within it, we do have county-wide actions, so there are a lot of actions that, because we have a multi-agency group, we have a lot of actions that are still be west and north, and they'll still be delivered in a joint way, but we do have some that are quite clearly marked as west or north, and that again is based on our local data. And as part of the strategy as well, we're going to have ongoing actions. So the ongoing actions actually cover the full 5-year period of the strategy. We have phase 1 actions, phase 2 and phase 3. And we will still be continuing with our quarterly county-wide meetings. And this is something we did ask our steering group members to see if they were happy with that structure, and they're still happy with that going forward. Our strategy, the new one, does align with the suicide prevention strategy for England, which is the national government guidance that actually came out in 2023, and we were halfway through our previous strategy at that point, so we weren't able to implement too much at that point, but we did add an additional priority area to capture some of the key groups. So all the priority areas that we are outlining in the new strategy, all 8 align with the national, but what we've got within it is what our population needs are for West Northamptonshire. Thank you, David. So I've highlighted there, it's across 2 slides, but there's 8 priority areas, and they've all been highlighted both in the draft document you've been sent, but also in the strategy as well. Thank you, David. And I wanted to spend some time actually just looking at some of the actions themselves. So some of the ongoing actions, so these are across 2026 2031, and these actually capture the things that already have been ongoing for quite a while. So we collect real-time suspected suicide surveillance data through the coroner, and that's a system that continues for us, so we've got that as part of that. We'll always be doing campaigns targeting high-risk groups, so an example of that was the male suicide prevention campaign. We support in domestic abuse, where we actually attend domestic homicide reviews and support from that suicide prevention perspective. Aligning our work with health inequality work streams, working closely with our local area partnerships to support where appropriate, looking at digital inclusion, so identifying barriers to digital access and implementing measures, and homelessness of sleeping strategy, looking at aligning with that and supporting the strategy, and of course bringing in any key actions to the strategy that overlap with the work that we do. Working with our commercial organisations, so this is in two ways, so helping to reduce the access to means, but also influencing policy changes within them as well. And suicide bereavement support. We currently have a suicide bereavement support delivered via Service 6 locally, and that is all age, and it's via the Coroner's Office, and they do the referrals into that service, so it's just capturing that work is ongoing for us. Thank you. In terms of phase 1 actions, so phase 1, as a reminder, is April 26 to October 27. So some of these have actually started already because we are now in June. So we have a big action around self-harm, and there's two ways that we're looking at self-harm. We're looking at understanding the data that's captured locally, so we are connecting with our Kettering General Hospital and Northampton General Hospital on that, but also some of our local groups. So Service 6, for example, have a community programme in schools with children and young people on self-harm, so we're working with them to understand the data. We're also looking at creating a prevention package for self-harm for educational establishments, and this has come about because of the work in the post-prevention package as well for educational establishments. We're also looking at supporting the implementation across drugs and alcohol of the co-occurring conditions with substance misuse, supporting the refresh of the county-wide all-age autism strategy, adopting a trauma-informed approach through preventative work, the development of an escalation protocol for suspected suicides where further actions are needed, and what that escalation protocol will do will outline where further action is needed but also where not. And then bereavement, so as I mentioned earlier, we are now promoting the general practice suicide and self-harm prevention and suicide bereavement resource pack. One exciting thing that we are launching in phase 1, but this is an ongoing action, is something called the Orange Button Scheme. This is something that was actually created by Lancashire and South Cumbria ICB, community members who have undergone specialist suicide prevention training. So this is mental health first aid, adults and children and young people, suicide first aid, adults and young people, assist and safe talk. They are eligible to become something called an orange button wearer, which means that they can be visible in their communities to signpost and support to further supports for anybody who's in distress. They will also be provided an orange button sticker that can be supplied to businesses and organisations such as cafes, shops and pubs that will alert people, members of the public, to know that there's a trained member of staff within that organisation to help them if they are in distress. We currently have a funded mental health and suicide prevention training offer in our community, so we've been able to go to everybody. There's been almost 300 people trained in that, so we've been able to go back to them and offer that orange button scheme. It's been out for about 3 weeks now in terms of us sharing any information about it, and we've had over 75 people come forward so far who are interested in the scheme, which I think is a brilliant, great first start for us. But that will be something we'll see over the life course of the 5 years. Thank you, David. Some of our phase 2 actions, so we have got some phase 2 actions, but we haven't ironed all of them out because we're anticipating that the work in phase 1 will help to understand what we need to do in phase 2. But phase 2 is December 2027 to June 2029. We'll be looking at actions around neurodiversity, so linking in with pre-existing networks and strategies. We'll be looking at training as well. So as I mentioned, we have a funded mental health and suicide prevention training offer at the moment, so we'll be looking at how we extend that into phase 2. After the work with the self-harm package, we'll be looking at developing an online harm support package for educational establishments in Northamptonshire, and we'll be looking at refreshing the post-vention support package for educational establishments in phase 2. We just did the last refresh in September of 2025, so we'll be looking at doing that refresh of the strategy at that point. And then also looking at updating and refreshing the core handler pack as well, which was also refreshed last year. Phase 3 actions, we don't have any identified at the moment because we're anticipating that work in phase 1 and phase 2 will outline what will be the prioritised actions for phase 3. I'm going to hand over to Claudia to the next bit.
Can you hear me? Yeah, it's working. So I wanted to briefly explain how the suicide prevention strategy sits within the wider Northamptonshire mental health system and how it is supported through the Mental Health Learning Disability and Autism Collaborative, also known as MHLDA Collaborative. So the first point is that suicide prevention is not the responsibility of a single organization. As the strategy itself recognizes, preventing suicide requires a whole system approach involving health services, local authorities, the voluntary and community sector, emergency services, primary care education partners, and already mentioned people with lived experience. The Northamptonshire Suicide Prevention Steering Group provides the county-wide leadership for the work. Importantly, the steering group sits within the governance structure of the MHLDA Collaborative. This gives the programme a clear oversight, accountability, and a route for escalation where system-wide action is needed. The steering group reports then through the population health and prevention pillar of the collaborative. This ensures that suicide prevention is aligned with the wider mental health prevention priorities, the health inequalities work, community resilience programs, and the population health initiatives across Northamptonshire. Regular updates are provided into the MHLDA governance structure, allowing partners to review the progress against the action plan, share the learning from across the system, and identify emergency risks and coordinate the collective responses. The collaborative also plays a practical role in supporting the delivery through the population health and prevention pillar. The MHLDA Collaborative has funded and supported the Northamptonshire Mental Health and Suicide Prevention Training Framework. This has helped and is still helping to build suicide prevention capability across the county by providing training for professionals, volunteers, and community members. This directly supports the priority 8 of the strategy, making suicide prevention everybody's business. So by increasing awareness, confidence, and skills across our workforce and communities, we are helping to create more opportunities for early intervention and support before people reach crisis point. So in summary, the suicide prevention strategy is both informed and supported by the wider Northamptonshire mental health system. Through the MHLDA Collaborative, partners are able to provide strategic oversight, shared accountability on collective delivery of the actions Artie just mentioned, and to reduce suicide and improve the outcomes for our residents.
I'll bring us to a close just by doing the governance bit at the end, just to show you where the report has been and where it's going. This is our West Northamptonshire governance route for this strategy. Whilst Artie has highlighted that some of the actions have started, the strategy still has that opportunity to go through scrutiny and then be endorsed by Cabinet later in the year, in September. And this aligns with the governance structure that the North are currently going through. I think they have their scrutiny in about a week and a half's time to have that input from their scrutiny panel. So it's just there to show you that process that we're going through, and the fact that we're trying to come to scrutiny at an early stage in the sort of governance structure to get your input before we bring it to Health and Wellbeing Board and Cabinet later in the year.
Thank you. I suppose this is our opportunity to ask questions and pick up. I just wanted to ask, in terms of West Northamptonshire, are we average for the country, or are there particular factors where we're different from other areas of the country, would be my first question to get us going. Oh, I'm sorry. I should...
So I did anticipate the question, so maybe actually I can just move this across from my laptop in here. There is data published nationally on a couple of different areas, one being on, for example, self-harm. So this is the data for hospital admissions as a result of self-harm in 10 to 24-year-olds. I think, Councillor Herring, I think when you'd previously done a report which I think cut out around this time point here, where we just started to see numbers come down. That trend has continued, and we have been narrowing the gap. However, we are still above where we, obviously, the national average. So heading in the right direction, but still lots of work still to do. In terms of suicide rates at a person level, so male and female level, we're sort of running at a similar level to what you would see nationally in terms of the same rate. This is always a bit difficult to do because, thankfully, they are lower numbers, and therefore that does cause fluctuation and differences quite a lot year to year, but consistent with the England average in that respect. So just a bit of a background for you.
So we're pretty typical, really. We don't have any unusual factors within our area.
So I wouldn't. I turn to Artie and others, but from my understanding, there wouldn't be any unusual drivers of suicide here that would be differ to what that's seen across the country.
Yeah, right. Yes. Rosie.
Sorry, I've got loads of questions. And one of the things that bothered me about data and how we collect is the fact that anything that happens in my neck of the woods will go to Oxfordshire, and I presume the same will be for Milton Keynes as well. And I don't think we're collecting the data in any sensible sort of way. And including those, I don't think there's a mechanism, shall we say, for actually collecting the data so that we get a complete picture. I was interested to know whether there's data to say that what the risk factors are from self-harm then progressing to attempted suicide, and whether that is a known. You've mentioned alcohol as being a trigger, but I don't know whether there's any evidence about self-harm and what percentage might then lead to a suicide attempt. I'm obviously batting for my area, but I've been aware, because NHFT is based in Kettering, a lot of the focus for crisis cafes and so on has been in the north, and in Kettering, with very little in the south. We've been a neglected area. In Brackley, Towcester, and even further south, there's just been nothing, and that obviously that upsets me. I did manage to get, and I'd love to make a recommendation about it actually, but it'd be interesting to know whether what you have put as educational training for suspected suicides and self-harm. I did manage to get for our local secondary school an input for the students taking exams. So we had a session on how to cope with stress and anxiety and so on, and I think that is something that they said it was really helpful, and I think that's something we could say a recommendation for this going forward to roll out, to make sure that all secondary schools have access at least to that kind of advice. I'll shut up now because I'll probably think of other things in a bit. Okay.
Right, Adrian, come on.
Thank you, Chair. Through you, yeah, that's some very interesting points there. Thank you. It's always difficult looking at the big picture mathematics because they don't always necessarily come out right. You know, from the report we can see that nationally what the statistics are, and it works out at almost 11.5 per 100,000, and we're at 70, which is about 16 per 100,000. So I wondered if there was a comparable breakdown between areas that have with our demographics, you know, with the rural aspects, the large town aspects, and if there's a comparable breakdown with those, rather than just looking generally over the population nationally from the ONS, it makes it unrealistic. Is there anything particular about West Northants, or North Northants for
all the localities within our area?
Yes.
Yeah, that's a very interesting and difficult question, I guess.
Some villages out, you know, ex-mining villages or whatever they have, you know, that it's comparable. Thanks.
Yes, David, come back on that.
Shall I try to come back on all of them? So I'll try and work through some of them, and then I'll end on that one. And Artie, I might come to you for some of the more specifics about some of the support in schools and others. So, and we were discussing this earlier about there has been some work to look at, there's been a coroner's audit to look at some of the sort of causal factors and looking into more of that detail in what some of those drivers might be of suicide and exploring that. And I think Artie and I were discussing earlier that there's a confidentiality form, but that can be shared with individuals if they'd like to have a look at it. Self-harm is listed on that list of factors that can lead to and increase the risk of suicide amongst other factors. So we can share the process to get access to that, so you can have a look at that in more detail.
And do you include eating disorders as self-harm?
I'd have to ask Artie. Do you know that answer to that one?
So the data that we get with the audit is how it's classed with the coroner audit files. So we would absolutely class that as eating disorders, including self-harm and risk-taking behaviour, so that wider umbrella of what it is that people are seeing. But what we are exploring through some of the self-harm data work is how self-harm is categorised and what is being used to categorise it, because there is the more traditional methods that we might think of which can really narrow down what is seen as self-harm. But if we look at risk-taking behaviours as a wider, then there's definitely more in that. So we're looking at that as like the smaller and the wider perspective.
And then trying to cover some of the other aspects. So in terms of the data comparison, we can look at comparisons to stat neighbours, and I'm just trying to look at it now on the computer. We're sort of near the lower end in terms of our, what am I looking at in particular here? In terms of our suicide rate, we are towards the lower end of our statistical neighbours. But we can get some more detail on that if that's something that you'd like. What I would preface that with is what Artie's just said, which is that different areas and different organisations might code things like self-harm slightly differently. So that comparison between areas is always complicated by some of that sort of nuance in how different organisations do it. Some of the work that Artie's doing with local organisations might end up to seeing some of our rates increase, but that's because we'd be capturing a wider spectrum of self-harm, which isn't necessarily a bad thing. So I can share some of that. It's take it with a pinch of salt in that idea that actually there's fluctuations in how that is recorded.
Is there any way that you can actually get data from the hospitals around us by postcode?
So I imagine it is something that could be done. What would have to be done, though, is to look at a long period of time, because what we are talking about is quite small numbers, really, to do anything meaningful with in terms of analysing it and getting meaningful trends or meaningful information out of things like the coroner's audit and bringing out those common characteristics, and then thinking actually which populations and around us are more subjected to those. I think is one way in which we look at some of those issues.
It's fantastically interesting about the coroners, but it's unfortunately that you're looking at the horses bolted by then.
Anthony's been trying to get in for a bit, so Anthony.
Sorry, can I just add to the self-harm point, if that's okay? Yes. I was just going to say that we are working closely with Kettering General Hospital and Northampton General Hospital on that data, as well as wider with children and young people groups with self-harm in particular. So we are exploring what we can get, and obviously looking at what's identifiable, etc. So that is part of it. Before we move on, sorry, Claudia has a point to mention about the crisis cafes. If that's okay to come in on that.
And I was going to ask, yes, talk about the crisis cafes, and then I might have a follow-up.
Yes, so I get your point, Councillor Herring, about the crisis cafes in your neck of the woods. So there is actually, for children and young people, they call well-being cafes or well-being drop-ins. They're delivered by the REACH collaboration, and in your area through Time to Talk. They have one in Daventry, one in Towcester currently, as far as I'm aware. And for the adults, crisis cafes, this delivered by Mind Northamptonshire. And they're also definitely in Daventry. I will check in Towcester or Brackley, but if you're happy for me to reach out to you, I can send you the details.
And
villages has been a desert for any kind of help.
For a long time, yes, but if you're happy, I can send you the information,
And I just wanted to check how sustainable the funding of those crisis cafes is at the moment.
Currently, there is no indication that they will be decommissioned, so they will be continuing with the a fundamental part of our crisis pathway and that prevention to specialist services. The adult crisis cafes delivered by Mind, Northamptonshire, and also Kettering, Mind. They are part of the MHLDA collaborative outcome-based contract. So, and that means it's quite sustainable funding within. So currently no indication, so it's going to continue.
Pinder. Oh, sorry, Anthony. I thought you'd. I'll get the hang of this in the end.
No. Thank you, Chair. Obviously, I mean, it's the first time here, and I think I do want to say, well done. It's really, really good idea. Any strategy that we have within North Hampshire to prevent suicide is a fantastic result, and I think it's a really good idea. I had a couple of questions, and Councillor Herring kind of like touched on it, but I want to take it a step further. So we have 70 suicides in Northamptonshire. Now, my question would be, well, there's a two-part question. The first part of the question is, we have 70 suicides, but and again, just because someone commits suicide in our county doesn't mean they were in our county before that. So are we analysing the data of people transferring in the county to commit suicide and the people transferring out the county to commit suicide? And the reason I raise that is my second point is when you talk about high priority groups, I would ask what are the high priority groups that you are concerned about? My own personal thing, being a veteran myself, speaking to many veterans, I know that male suicide, particularly amongst veterans, is really high at the moment. And many veterans, they will not seek help. They will not go because they are too proud. It's the same reason many veterans don't go to food banks, because they're too proud and they won't seek that help. So my question be, firstly, are veterans also highlighted as a priority group? And are they also, because they will travel, they will go to Wales, they will go down, you know, they'll climb a mountain and commit suicide down there, but they would have, you know, lived in Northamptonshire. Is that being addressed as well? Thank you.
So when we get the real-time suspected surveillance data, so we get a report from the coroner's office, but that comes from the police. And what we do ask for that in there is it often tells us if the individual was in the county or not, or born in the county or not, so we can often get that data quite quickly on that. We have also had scenarios where an individual lives in the county but has gone out and taken their life somewhere else in a different area, but they still coordinate with our local coroner's office on that because they know that the home postcode is here. So we are able to collect that data. And when we have the breakdown, in our quarterly meetings, we present a lot of data on a quarterly basis around real-time surveillance, and we look at the percentage of those that are in the county, outside of the county, and those born, etc. So we get an idea of that breakdown from there. The veterans question does come up quite a lot for us, as you can imagine. Absolutely, we do. When we have the largest part of our data comes from something called an audit rather than the real-time surveillance. And the audit is where the coroner has completed their investigation and reached that verdict of suicide. Myself, a data analyst, and another member of the team at least will go into the coroner's office and we will look through those files. And the whole point of that is to understand the preventative factors that could have been in place to stop that suicide from sadly taking place. And there's lots of things within that, you know, toxicology reports, there'll be last notes from the individual, there'll be, you know, friends and families reports, etc. as well, which gives you a lot more information about the life of that person, as well as GP reports, etc. But what we do rely on that is for those certain questions to be asked and for that data to be shared. So things around neurodiversity and veterans can be a little bit harder for us to get the data on unless that is in that audit file and in that system. The coroner audit we do every year, so we produce a report every year where we add on to the 5 years worth of data that we've got so far on suicides across Northamptonshire. Does have a section about veterans in there, and it looks specifically at that particular population. It is quite low for us in Northamptonshire, but that's not to say we can't do more pieces of work. What we do see and what we have done, which would, you know, connect with some of the work with the veterans, is for Northamptonshire, males represent around 75% of our suicides locally, which is comparable nationally. So that male suicide prevention campaign is something we did as a targeted piece of work across the board to all males in that. Now, in West Northamptonshire, it's actually an older, middle-aged and older cohort, so 45 and above, which is comparable nationally. But in North Northamptonshire, it's younger, so it's 25 and above for them. But we went to kind of all-age males with that, and all those males that have come forward have really different stories and different backgrounds, and we wanted to produce a campaign that would, you know, speak to anybody, whoever interacted with it, regardless of their background and where they have come from. But that's not to say that just because we've released it, that's the end of it. We're always looking to expand on that with the stories and the people that are there as well. So yeah, it's definitely something that's come up for us, and it's definitely something that we are very mindful of in the work that we are doing.
I think Pinder was next, and then can I work along the line there? And then I think Hayley's trying to...
Thank you, Chair, and thank you so much for that report. Again, when we're talking about suicide, for me, the experience has been with a lot of young people talking about it, self-harming and so on. And one of the things that I feel that's needed is more resilience work with young people. In terms of, I don't know about anyone else, but I've got a 19-year-old son, and I've got friends, and we all talk and everything else. And, and even speaking to residents as well. And it seems to be a real thing where a lot of young people aren't coping with just things that we coped with 10 years ago. They just cannot. And I was wondering, as part of the suicide prevention work, is there any kind of resilience work that can be done, long-term with schools, and obviously joint up with different kinds of organisations that we could work on? That was one. And the other question was around, I know you mentioned that there was some training with the schools and so on. How joined up is that in terms of the support they get? Is it left to the schools, or are we working with them in terms of public health and making sure that they're getting the right support and everything in place? My final question was, as counsellors, I think you mentioned training. I think it's really important that counsellors do get that training, are able to spot those signs if they do come up, because you do get the emails of people that are desperate and they're asking for some kind of support. And to be able to flag up if we think that there is a risk of suicide somewhere, what that process looks like as well. So that would be really helpful to know. Thank you.
I'll just come in firstly. I'll go back to front, and then Artie come in and add extra, because you'll have plenty more detail. I think Artie will bite anyone's hand off in terms of if there are volunteers to take on to the orange button scheme, and how we can explore training for elected members who want to be part of that. So definitely, I think that's definitely something we'd happy to discuss. On the schools, and then Artie can probably fill in more. I suppose I'll highlight two things. One is the mental health support teams that are working across schools and working their way through to work across every school across West Northamptonshire, and provide that sort of support to schools around those low-level mental health support. But also I'd highlight from a public health angle some of our work on healthy schools, and actually starting even at that primary school age, and how do we build in mental health and well-being into the way that children are sort of educated, and bringing that sort of resilience from an early age into their work. So Michelle in public health works closely with schools from across West Northamptonshire, and we're encouraging more schools to take part on our Healthy School Awards, which gives support and materials to help schools think about how they incorporate well-being into their school day. But Artie, did you want to add some more?
Yes, thank you. So with the schools, so there's been some new government guidance that has come out around PSHE, and with secondary schools in particular, they've been asked to actually deliver more around suicide prevention for that age group. And it's not delivered as suicide prevention for the younger cohort, but around, consent and healthy relationships and looking after yourself and knowing when you're well. And actually, Healthy Schools team, so as David mentioned, Michelle has been leading quite a big piece of work with the North, the Healthy Schools team, without us being involved from a suicide prevention perspective in how we can help the schools with that. The schools have been given this guidance, but there's a lot of tools and organisations available locally that can help them to guide them in those conversations. So we've had 2 conferences now with schools across Western North to attend, all age, where we've delivered a session specifically on suicide and self-harm for them, so that they're aware, and we've shared a lot around the resources that were available and other organisations that are there to support them within that, from that education perspective. And in terms of training for schools, with the mental health and suicide prevention funded training, we've got a significant number of schools have taken up on that training and have come forward for that, because it is funded. It's obviously an incredible opportunity for them to come on board. There is certain criteria around it, so it is limited to 2 per organisation, but it is, it's shared with people who are like designated safeguarding needs and things like that, who are likely to be the individuals where things are escalated to. and they're able to have those conversations. And through the funded training, we offer mental health first aid and suicide first aid, both children, young people, and adult as well. So depending on the cohort that they work with, they will have that relevant. And mental health first aid will go a lot more into self-harm and suicide, as well as other things in that as well. And then, yes.
Kind of thought on something. So schools, fair enough, training, we're talking about the funding. What about places of worship? So obviously when churches, for example, you know, you would get the local vicar, for example, and someone might want to come and talk about something. Is there any kind of training or any kind of funding that they could access as well? Yeah, thank you.
Yeah, so the funded training is actually available for anyone across Northamptonshire to attend. It's not just schools, so it's workplaces, you know, people from faith organisations, schools, etc. It is literally available to all, really, because we wanted everybody to have the opportunity to come, but we did also want to make sure that not one organisation sent like just 10 people on a course. So that's why we really structured it in a way so we've got people from all different backgrounds. But we do have it on the with the local area partnership work. They do work really closely with the parish councils and churches. Temples, etc. So we are linked in with that work as well.
Thank you. Alison,
can I just, sorry, I was not quick enough.
Yeah,
I just, whilst you were talking, Artie, I just had another thought around this resilience for children and young people. And Artie mentioned that earlier in her presentation. There's a project called the Opal Project, which is delivered by a service, Opal, O-P-A-L. It's actually born in Brackley. Yes. Yeah, and still going. I know it's a long time, 2004, it's still going. And it's delivered by Service 6, and it is for young people who are self-harming or showing risk-taking behaviours, and through that project, resilience work is delivered. But of course, it's always a question of funding if we can expand it or not. But that's another tool we are using. Yeah. No, it's across the county. Yeah, it was born in Brackley and then rolled out in 2009, I think, if I remember right. But yeah, it is county-wide. But if we want to expand the target of it, then it needs more funding behind it. But that's another tool Artie and the team can use to roll out for resilience building. Thank you, sorry.
Thank you, Chair.
Alison, come in.
I have a name, it's Alison. Thank you for your presentation. It was actually very interesting. My one criticism of it, in fact, may well have been addressed just now, because nobody is a statistic. These are not numbers. We are people, and we aren't always around when the journey towards suicide begins, and it doesn't always start with harming. I'm led to believe there is a dynamic in, for instance, the farming world, where there are a lot of farmers who are led to commit suicide, and yet in their cabins all day nobody finds them. And is it worth us looking at the behaviour of groups of people, and maybe this Opal organisation can investigate it, so that people are not a statistic, but they are a group of people that we recognise that are vulnerable. And I think we may well find ourselves with the COVID body of kids that actually, when they get to 14, 16, 18, have a lot of problems. And we need to be ready to catch them where they fall.
Thank you.
Yeah, thank you, Chair. Very good report. I think echo what everybody else has been saying. Thank you very much for your presentation. One of my questions after reading the report was going to be about what is the orange button scheme. So thank you for explaining that to us. I think that sounds really exciting, that actually, and I think maybe it's worth, if you're going to update the report, putting that in the appendix so people can read about that as well. Yeah. And I think that's something that you talk in about working with the LAPS and parish councils. Sounds like that would be a really good initiative to take to them as well. Question I had around, you talk about place-based actions, and in the action plan to October 2027, just wanted to understand what you mean by that, because you've got some of the actions are against NNC or WNC. does that mean that they are leading on that for the whole of the county, or is it just for that area? So, for example, it says implement a staff bereavement support network, NNC. Well, I hope it's not just NNC. I hope it's WNC as well. So perhaps you could answer that. I've got another couple of points after that.
Oh, well, I think we're...
Do you want to carry on with another point?
Well, yeah. I want... Can Hayley come in? And then I think we're going to need to draw our discussion to an end.
Yeah, okay. Can I just make one last point?
We are... hang on, we could all make more points, but I think we are running over time. I'm going to get Hayley to come in, and then we'll...
Yeah, my points were on bereavement and also substance abuse, and that links in with particularly youngsters, maybe more so than older men, and not just young males, young females as well, and all across the board there. So really I wanted it to have a bit more of a breakdown there, and I wanted to ask about crisis cafes. How could, and again I know it all comes down to funding, but how, if any way, could the council be more creative, working with the parish councils, and have crisis cafes outside of the usual times? Because it's a huge, the social isolation is huge across the board, but particularly for the youngsters. The substance abuse leading to mental health, leading to, and also get my words right, bereavement. Bereavement is huge. I think it was something like 42% within 3 days of suicides, which is sad, isn't it? And that stems across the board. What can we do more there? Can we link into the VCFSE sector more? Thank you.
Do you want to come in and...
Shall I start off while Artie, you can write your thoughts around some of those more specific areas? I'll come back first, I think, around the cohorts, because I think I'm very much in agreement. This is not a strategy that's about data points and about statistics. It is about real people, and that's why lived experience has been real at the core of it. And I think it's a lesson for us, I suppose, in terms of how do we get that across, because what Artie's described is some of the work they're doing around that audit, around how they delve into each individual case and try and understand the person behind that statistic in each case and learn from that information. I think what we can do better is maybe describe some of that work that's ongoing to make sure that that comes across more, and so that people realise that we are doing that work on a regular basis to review individual cases and learn from those stories that people live, rather than just the numbers.
If I come in about the bereavement, I'll keep it short and sweet. The ICB funds cruise bereavement support across the county, and that will continue. And it also funds, and that is a NHS England mandate, that each system needs to have a suicide bereavement support service. We have one since 2021, and this supports people affected by suicide, so the next of kin to start with, wider family, work colleagues, school friends. And if we have, and it relates to what you said earlier, if we have a suicide in Northamptonshire, but the person is not from Northamptonshire, the family still gets referred to our service and then links with the service where the family actually lives, if that makes sense. So because each system has an called SPSS. So there is bereavement support funded out in the county.
Right, I'm keen to draw the discussion.
Sorry, can I just say one final point just to the council at the end? So where it says that example that you used around the bereavement cafe in the north, what we can do is make it a little bit more clearer in the strategy. So we already have one in the west, and it's been running for quite a while. So north don't have one, and they saw what we were doing and wanted to implement that as part of the strategy, as part of this. But what we can do is add a bit of that subtext, so it kind of provides that history. And then just the farming community, I just want to say that we do have individuals from the farming community network that sit on our strategy as well and work with us on some of the things that we're doing, and some of the things we've done for World Suicide Prevention Day previously have involved us going to the farming community and some of the markets, etc., where we've taken like the sulphur and things like that to them into their communities.
I just want to, at this point, I think it's about we've got three outcomes from our discussion today. One is, do we have any particular recommendations that we want to make in terms of developing the strategy? Have we got specific recommendations that we want to pick up? And are there any issues that we really want to get further information on? And how do we carry on as a committee to review I mean, in a way, this is the strategy. Will we see the action plan, I suppose, would be the next thing we'd want to see. And then how will that be monitored? I suppose there is that whole question of this is the kind of pre-scrutiny. We need to look at what are the outcomes. So, yes, Rosie. So I'm looking for specific recommendations for the committee so that we have something to take away.
Two things, but I would like to, and it links with obviously the Children's Committee as well. But my first suggestion of the recommendation that we offer pre-exam sessions with secondary schools to how they cope with anxiety and stress. Yep. One of the things that I wanted to say, but you were trying to close us down, but I thought it was really important. We've not mentioned social media and the effect of social media. I know that there's going to be a ban, but who's monitoring this stuff? How does it get reported? How does it get taken down? So I think that's an aspect which hasn't been covered. Right. Rather important one.
To that, Chair, sorry, because I was going to mention AI as well, because obviously this strategy started a while back, and this new technology is coming in very rapidly, and there has been cases where AI has been influencing people's behaviour, and I think that needs to be taken into consideration as well.
Okay, is there anything, Pinder? Yes.
I just wanted to add about the resilience piece being added to that. So if we can link the AI, the whole mention about. God, what did you just
that was pre-exam.
Yeah.
So
linking all that together to building resilience in young people.
So we want to put that in, and the area of AI and technology.
Social media, that was one.
Social media and technology. Anything else we want to kind of add? And also, I think there's something about just looking at how we work this into our work programme in terms of the action plan, and then some sort of report on progress over. Perhaps we almost need.
I can make a recommendation if that's useful, which is Artie's outlined how phase 1 runs until December 2027. It may be that in early it seems like a long way away, but early 2028. We come back and you can have a look at the work that's happened and the progress that's been made in phase 1 and how that's informed phase 2 and phase 3.
That sounds good. Yes, excellent. Hayley, quickly, and then we.
It's just a recommendation. I don't know if it's quite for this this strategy or whether it stems across assets, but it would be to look at the council resources. I know obviously MPH, that's Northampton Partnership Homes that the council own for this social housing. They have community hubs, and those community hubs are certainly free for the residents in those areas to use, or very limited costs, favourable costs. So could we be creative as West Northamptonshire Council in tapping into those properties that we've got, in using those to offer any more support?
I think that's a very interesting question that we should ask. So, goodness, we've overrun our. Alison, we're going to have to finish.
No, I just got two things.
Yes.
Who amongst our officers is in charge of suicide? Who? You are. Thank you. Who is in charge of, amongst our cabinet members, is suicide? Thank you.
Yeah. So, I think we've got some recommendations. Richard, do you need to read them out, or that's fine? I think the length of our discussions shows the interest in this issue, and I very much appreciate the work that's gone into the strategy. Thank you for your time this evening. We're obviously, we are more interested than the time we have available to discuss it. So thank you very much. Yes. Yeah.
Thank you, Chair. Just for information, on the West Northants website, the mental health and wellbeing section, there's a lot of training on there, and also I believe RT's emails always have the ZSA, the Zero Suicide Awareness, and they have free training courses for people to do on there, so they can help people if they're struggling, just in case anybody's watching or interested. Thank you.
Excellent. Thank you very much. Thank you for your input. Right. So, Maria, we come to you. So, I mean, can I ask Richard just to introduce us, just to give us a bit of context as to how we've got to where we've got to this evening? Because I think members will find that useful.
Thank you, Chair. Did everybody receive my email the other day? Excellent. So that hopefully summarises where we are. So we had a session recently to come up with a number of questions for the ICB. Myself and the Chair met with Simon Deacon from the ICB earlier this week and essentially put those questions forward and developed that into a programme of regular scrutiny. So we'll have an introduction from Maria Laffan tonight and then we've grouped the questions that were asked into several themes that will form a rolling pattern of scrutiny at all our meetings over this municipal year. So we'll hear from the ICB regularly at every meeting rather than once every 12 months, which I think represents a vast improvement for everybody on what we had before.
And is it just worth just recognising the role of this committee in terms of health scrutiny? We are the place where the NHS and local people come together. This is the point. This is the point of sort of local accountability for the local NHS in all its different guises, all its different elements. So actually we have a very significant role in looking at our local service, understanding our local services and feeding back the experience of local people in terms of where we are and where we think we need to be. And I know from the number of questions that we developed at our session last week that there are lots of concerns and lots of questions which we have to break down into manageable chunks. Otherwise, we will be here till midnight and we won't get out of the car park. So on that, starting there, Maria, do you want to come in and just sort of set the scene for us?
I will. Thank you, Chair. And hopefully I'll make you catch up on some of your time allocated for this evening. And I don't have any intention to answer the 30 questions this evening either, so I can do a little bit of scene setting from where we're at. Probably just helpful for me to outline that whilst I speak to the model, if you like, for ICBs and where we're at from an LNR, specifically Northampton perspective, we have established our executive structure across the cluster. And as a group of executives, we've identified roles that align to each of our place areas. And whether you like it or not, you've got me. So I will be a nominated representation here around HOSC for the future and also around the Health and Wellbeing Board for West Northants Council. But I guess just the opening slide really is around how we're building our cluster across Northamptonshire, Leicester and Leicestershire and Rutland ICBs. Colleagues may be aware of where this started with, or the first round of model ICB legislation that we saw, and that is just over a year ago now, back to May 2025, when we saw the version 1 model ICB strategy that started to challenge us around our makeup and shape of where we're at as commissioning authorities up and down the country. So I'll go into some of that detail in the slide and give you a sense of where we're at now, with the caveat that we are going through a full management of change in our structure to land with a final cluster position. But we are still currently in a position of existing statutory bodies, as in Northamptonshire ICB and Leicestershire and Rutland ICBs separately. Next slide, please. Thank you. So this slide hopefully talks you through some of the refreshed role from a national perspective. And this is the guidance we're working to as per model ICB and what system architecture should look like. So the ICB, if you like, is the green part of the rainbow here. So we still have a role around commissioning services for our local populations. There's a new language around that is to be strategic commissioners and a real focus on population health. And that is a seismic shift from where perhaps we have been operating in the past. Colleagues also will be aware around some of that national policy around left shift, more care being provided in our communities, locally, more accessible, and the building of new neighbourhood health services, which I know you will have had documents here before. The national responsibility around setting that strategy, setting the national leadership, identifying priorities and allocating funding. And I'll go on to speak a little bit about allocation of funding a little bit later on. But I guess the importance of it here in this slide is around ICBs in their new format having to live within their allocated allocation. If you like, and that's the difference that drives our strategic commissioning approach. And then again, another shift around the responsibility for the delivery of effective quality of care. We have got that anyway, haven't we, across all of the providers where we commission healthcare services from. But that shift is much more aligned now to our providers of healthcare, those who have accountability and responsibility, whereas commissioners are much more driven and focused about the intent around our population health needs and strategic commissioning. So I'm mindful that might feel a little bit busy, but it is deliberately centred around commissioners in the middle there to give some description around some of that operating model. But in the centre of it all, a real focus on people, needs and priorities. And I'll talk to priorities a little bit more. Next slide, thank you. So why is there a change needed? I won't go through all the details of the headlines here in the slides, but there is a real refocus, like I say, around this strategic commissioning for population health. There's a national need for this, and it is driven predominantly by prioritisation of health need, but also effective use of resources that focus on health outcomes, reduction of inequalities, and being sure that we use the limited resources we have across health to deliver the maximum benefit to our population. We have seen revised resourcing. We are very clearly being advised that we live within our allocation, and because of that, what we're seeing is this move towards a reduction of our running costs and averaging that out at 50% nationally to meet that expectation. So that looks like £19.40 per head of population. Don't ask me any questions on the math. Somebody did that nationally. I won't pretend that I know the rationale and detail that sits behind it. But what that looks like across Leicester and Rutland is a 33% reduction, and in Northamptonshire, a 29% reduction, and that's based across the 41 ICBs. A focus on collaboration across our regional footprints. So it allows us to look across with our respective ICB colleagues, regionally in particularly, around what are we doing 11 times over, or what have we been doing 11 times over, and what's the opportunity if we start to cluster in a different way where we can be more efficient with the resource and spend in that area. Next slide, David, please. So that's some of the rationale nationally as to why that's changing for I said 41, 42 ICBs, I should have said. So in the Midlands, where we are here, then that starts to look like where we have had in the past 11 ICBs, we will see the formation of 5 clusters. So I'm here as a representative from the LNR cluster. Like I say, we're still going through a full management change process. We haven't got people in fully identified structural roles yesterday, but we're in the midst of that and should be coming out the tail end of the end of July with that finalised. But our colleagues, as you can see, for the rest of the regional, area looks like Derbyshire, Nottinghamshire, Lincolnshire, Birmingham, Solihull. I won't read through all of them. You can see them aligned there. But what it does start and has started to give us opportunity around is what are we doing? What were we doing 11 times over? What can we be sensible around our resources? And some of those conversations are live currently. Next slide. Thank you. I guess some anticipation for the questions around what does clustering mean? Well, for now, what it means is using, where possible, that approach of not doing things twice across our geographical areas, but the organisations will still have single board governance. We have a single board. We have a unified leadership team, as I said earlier. Our executive structure is in place. We've got a team of 6 executive leaders working across the cluster. And we now are in the process of building this transformational cluster across all of those geographical areas to meet the 10-year plan that was set out and challenged us some time ago now, with a focus on health outcomes and with a focus on we have a limited resource and a focus on what do we do with that and how do we prioritise. So like I say, in early stages of clustering, and there is some national noise around merger as well that I won't go into the detail here. It's very, very fresh, but I know it has been discussed around our public board, our private board at the end of last month. Next slide. This will be very familiar to colleagues in the room. So for the total cluster population size of 2 million, 5 places, 20 neighbourhoods, 5 HOSCs, so hence you've got me and my colleagues are out in elsewhere, 5 local authority, 42 primary care networks, 5 provider trusts, and a 5 billion total budget. So it's a busy space and it's a big challenge as well. But that's just that's the sort of highlights of they're the areas that we're focused on, and that's the total budget that we're working within. Thank you. You'll be familiar with this, but these headlines you will have seen in many areas. These headlines talk to a reasonable population size across children and young people, also a very large working age population, and significant across older people communities as well. And just the detail on the slide gives you some of that focus around our areas of deprivation or most deprived as well. Thanks, David. This is the strategic commissioning approach, and it's something that, if you haven't heard it to date, is certainly a live language in ICBs. But this was really what came in the policy around model ICBs. So in principle, understanding and knowing our local populations. So assessing population health needs, those underserved, and looking at where we've got good performance or not so good and what we need to do about that. A long-term population health strategy, and I know much work was in place ahead of model ICB work, but this is around refreshing some of that. Delivering the strategy through payer functions, and some of that language is maybe new and unusual to colleagues, but that's really been really clear around what are we responsible for buying in our Commission of Health Service, and what level of oversight do we have around that, and what does good look like effectively. And then looking at that impact of, if we have had the responsibility for buying resource on behalf of our population, what sort of outcome is that delivering and how are we measuring that? So that's the whole sort of cycle of strategic commissioning. And these are the areas really that I've touched on already that underpin our strategic commissioning. So specifically the improving population health and making sure, certainly within my role, that whatever we commission is good, safe, quality care. Being accountable for our health budgets. And so we're very much more having to look at what have we got to spend and how are we going to allocate that and where are our priority areas. Again, real focus on our population health strategy. Commission and investing and evaluating services. So, you know, we are in that challenged financial position around how do we balance the clinical need and financial risk across our system. So that really feels like aligning our resources strategically with longer term health outcomes. Again, I think I've probably talked to this, but this is how we're designing our cluster, very much focus on population needs, our statutory duties, so we're really clear that that's not going away. There may be transition over the coming years, but for now we have clarity around our statutory duties, our relationships, our partnerships, and very importantly, our patient flows. I'm mindful this is a really busy slide, but it tries to chunk up into core commissioning. What do we have to do? You know, what doesn't change? What are these areas? And some of the areas that have been spoken about earlier in today's agenda, like access to mental health services, improving mental health services, maternity care. We're going to get a publication from the latest Ockenden report in the next day, I believe. That doesn't go away. Those priorities still exist, so we have to continue to do that. But as a strategic commissioner, we have to look at what our transformation priorities are. And these are the three that you'll see in the amber section in the middle that we are working through as a priority based on our population health data and understanding around that, but also based on what we know and what we need to prioritise. So frailty, our activity across community settings, also our activity, and we see going through our doors of our ED department and some of the challenges around that. Mortality, some of it again in the suicide prevention conversation earlier today, but looking at where we can look to improve outcomes for patients, whether that's some of our cardiovascular, metabolic disorder type presentations. So our Chief Medical Officer is working through with colleagues around how we push that agenda forward. And then most definitely children and young people. And in brackets it says mental health and LD. And that's not there by mistake. That's an absolute deliberate action there because we know we've got significant and growing waiting lists for our young people with ND pathways. And so we've really, for this strategic commissioning era, really focused on ND as a priority. And the partnership bit in pink is still as important as it ever was to us, because without that pink area of working in partnership, we won't be able to deliver on our strategic priorities in the way we set out in our ambition. I think that's probably the final slide, but just to say that all of that priority is underpinned by us developing our target operating model. This feels live for us at the moment, and I don't think anywhere we'd be coming out and saying, here we are, we've published it. We're still working through this, but it absolutely is aligned to the 10-year plan, hospital to community, analog to digital, and sickness to prevention.
Thank you. That was a real whistle-stop tour.
It's okay.
Brilliant. So just to get the conversation going, I just want to clarify the board structure.
Yeah.
So are we saying that there is still the Northamptonshire board, or is there going to be one board for Leicester, Rutland and Northamptonshire?
We're working in common. We're working as one board in common.
Right.
That may very well change under the new ICB merger guidance.
Yeah.
And I just won't go into the detail of it because I'm not close enough to what that absolutely means here today. And
so
I think
the structure may well. So we've got effectively a shadow single board for the whole area.
We have.
Yeah, right. And I suppose given the work we do locally within West Northamptonshire in identifying health needs as a public health department, local authority, how is that built into your assessment of health needs at the, I'll call it regional level, but at the ICB level?
Yeah, I might come to David a little bit for some of that, but we have got a reasonable size intelligence function built into our team. And we're really keen not to lose that and to enhance that where we possibly can, so that our focus is well informed. You know, that it's not just numbers like my colleague had said earlier, but that we have real understanding of current outcomes and that is informed and built into that. But of course we are very dependent on data as well. And our BI leads, I know, will work with David and colleagues across public health.
Yeah, we've got a I can't even say the words, memorandum of understanding with the ICB that sets out where we can support each other on various different aspects, including on assessing need and understanding the needs of our population. So we're very much involved, particularly at the moment, in some of the work around the outcomes framework for the ICB and how we understand what data we need to sort of monitor some of that strategic commissioning in the future. The cluster has allowed us then to work across the 4 local authorities to think about how we use public health expertise as well as place-based knowledge, but public health expertise more broadly to support the ICB.
Can I just put, I think the relationship we have between West Northamptonshire and the ICP is going to be crucial. You're our single point of contact. How can we make that really work, I suppose, is the question.
Yeah, I would say this, wouldn't I? But I think it works well already. And
Right.
I think my relationship with public health colleagues, my relationship with directors of children's services, adult services is well established, actually, very early on in role, which I think is really, really helpful. So I'm confident that that's a good starting position. And look, I wouldn't say that I am your only contact for the ICB, but I certainly am an allocated executive for the purpose of West Northants. So there is an available resource of myself and the rest of my colleagues for the purpose of health and wellbeing boards, for the purpose of health overview and scrutiny. The reality of it is we are shrinking in size as an ICB, and you've seen the geography of that. There's just no way any one of us individually could cover all 5 at any one time. So we're trying to be pragmatic, but equally supportive and working in partnership to do that.
Tony, I think you... It was pin... Well, right, okay. Come in.
Thank you, Tony. Just a very quick question. I'm so glad you're here because I've got a question that I've been. I talk for every councillor here. There's a lot of development going on, as you're aware, with house building across the whole of our area, and with that naturally comes the question of GPs and health infrastructure. I'm going to be very specific about something that's currently happening in my ward at the moment, which is we have got a real opportunity where we were going to have a school built. It's not going to have a school built anymore. The developers have offered that land now to our local GP surgery. They're having that conversation. The GP surgery is happy to pay for it, and they have the staff to run it. What's missing is a meeting with the ICB and public health. So, David, that's you. So I did send an email actually a few weeks ago. I didn't get a response. So it would be good. I think Stephanie Gilbert emailed you into that. But it would be good to get a collective response on that because it's an opportunity where I know they've been planned in other areas where that would take a good 10 years to find the land and develop it and everything. This is an immediate opportunity. But there might be other areas very similar to that across West Northamptonshire that could have similar opportunities. While we have developers who are happy to do that and work with us, it's an opportunity we should grab. Would you be the right person to speak to? Would that be someone else?
Sorry, excuse me, can I just have a point of order?
Sure.
Councillor Chowdhury's question, it is very, very question.
Yeah.
But I think because of the way we were given the information before, we are only to discuss certain areas each time the ICB representation comes. So I believe that was for a later
I think there is a yes. I mean,
timing.
It's an example of a particular issue that is relevant for West
I'll answer it briefly.
Yeah.
It's not me. If that's helpful.
Could you help me find the right contact?
But I can tell you who it might be.
Thank you.
Appreciate that.
Thank you.
I think through you, Chair, the matters of individual casework can be answered outside the meeting, but as the right people in the room, it's been asked, it can be taken away and a direct response can be provided to yourself.
Thank you. Yeah, thanks a lot.
Tony, come in.
Thank you, Chair. Thank you for the presentation. It's great to see the NHS are sticking to its guidelines of plain language and making it simple to understand. As a medical professional myself, I'd find that quite hard to understand, and I'd like to bring it back to residents and people of Northamptonshire. if I'm understanding this right, and this is in several parts, so the Integrated Care Board or the ICB, they were asked to make cuts of up to 50%. And that was last year. Now, I'm under the impression that they were asked to make further cuts this year. And my question would be is, bearing in mind we have a service that has been operating for decades and has provided commissioning services across a broad spectrum of healthcare for our residents in Northamptonshire. And they've been told they've got to make 50% cuts, they've got to create further cuts, they've got to go from a localised service to a regional service. How can our residents be assured that they are still going to provide the same commissioning capacity, the same strategic planning and the same assurances to our residents and elected members that these essential services are still going to be provided? Thank you.
Thank you. Thanks for your question. And I completely echo the sentiments around NHS language and making that simply understood for everyone. If I can attempt to try and provide some simplicity around that, you're absolutely right. 50% reduction on running costs. And I was going to say and remember, but that assumes everybody knows the ICB structure and setup. Our running costs for integrated care boards are predominantly staff running costs. So they're not reduction in commissioning budgets specifically, but actually that will be part of the allocation of resource. And it's a real challenge, actually, and that's not to seek forgiveness around that, but it's a real challenge to look at what are the priority areas for your allocated population, and how do you make the best use of resource when actually it is being cut, and it's being cut nationally. It's not a local decision making. I think the question you ask around essential services, that's a difficult determination around how any one of us as a member of a population would describe and decide what an essential service is, because it means something individually to all of us as patients and as members of the public. What we've tried to share here today is, based on the information that we have, working in partnership with our public health colleagues, we have a greater understanding of what are those population health needs and absolute must-dos, and what can no longer not get the focus it deserves, like children and young people in neurodiversity, like frailty, or like people dying earlier than they should be dying. So we've had to refocus how we allocate our resources, and that really feels like what we're being asked to do around strategic commissioning, understanding your population, knowing the need and demand. But what that will mean is that we won't be able to commission everything, perhaps in the same way as we have done previously, but also it gives us the opportunity to really focus on what we are commissioning and making sure that what we are commissioning has good outcomes, like as David suggested, is set in the early stages of the outcomes framework.
Rosie, come in.
I suspect you're going to have another reorganisation when Andy Burnham gets in, having been a health minister, so you may be quite busy, you might be coming back quite a lot. But if you have to either ration or stop providing something that you have been doing in the past, given you the budget constraints, do you still have a duty to consult? Will you come back here, or will you go to a wider consultation with the population if there is a significant change? I do believe that that has been a requirement in the past. Is it still?
I think so, and I'm sorry for that being a really woolly answer. I'm by no means a governance expert, but I think your point is, if it is a significant change, would we need to consult? And I expect so. I know that's not a detailed answer, and I don't want to give absolute confirmation on it, but I guess it will depend on specific areas, significant impact. What I can tell you is, if there's any area that we're looking to either reduce funding for or to use an old sort of set of words, to decommission, then we'd absolutely take that through initial first process internally around what are we looking at, what's the potential impact, what do we understand about that service. So we'd have an absolute process around it. But I don't want to answer something that I'm not answering absolutely correctly. I expect there would be a need to consult depending on what the intention would be.
Tony.
Thank you, Chair. Just two questions. One, and I don't expect you to know the answer to this one, is could you, if possible, let me know how many staff you've reduced by up to this point over the last, if we say since the reduction was known? So what's the total loss of staff? And if possible, could you break it down without obviously identifying types of staff into like whether they're clinically trained or non-clinically trained, what their job roles are, not as in specific job roles, but their job sector, so we have a better idea of that. And the second part of my question, which has just gone right out of my head, was, in fact, I'll come back to you on that second point in a second, all right?
I don't think I'm in a position to share that because we're still live in our management of change process, so I wouldn't want to share that just yet. And we still have, like I say, that process is still working through, but I could come back to that detail at a later stage.
And sorry, it's just come back into my head, my second point of that question. What is your kind of like measuring standard? So obviously we've got this reduction, you know, it's been reduced. How, because I always think about how do we measure success or how do we measure failure? So what is the process that's going to be involved? Is there a 3-monthly review, a 6-monthly review, you know, a yearly review? How is it being measured? And what optics are the measurements being taken from of whether you are succeeding or failing? Thank you.
I think I understand the question. If your question is around the impact of reduction of staff.
No.
No?
Service.
What service?
All the services.
Commissioned health services?
Yes.
So we, like I described, we have a process of quality impact assessment for any changes being made. And we will bring that through our relevant committees for review in a timely way around impact. So we do have a process set up, but I don't know if you were speaking to any particular service or just any decommissioning process.
I think it's around a number of services, and I don't want to be like Councillor Chandra. I don't want to move into the other areas of GP services and be specific with services. My point is more about, we had the Integrated Care Board as it was formerly. It's been asked to make 50% cuts and now further cuts. My question is what is going to be the long-term impact on services about the ICB's level of being able to provide the service to residents of West Northamptonshire? Now, again, I know that it's all a fluid at the moment. My point is what safeguards or what safety measures are being put in place that, hold on a second, this isn't working, we are failing, we're not able to provide services, we're not commissioning enough GP surgeries or whatever the services are, whether it be, you know, health services, health visitors or whatever. You know, what safeguards are there to say, well, we've got to stop, we've got to review, we've got to go back to looking at this because we're not providing the same level of service that we provided before.
Yeah, thank you. I mean, we still have all of the feedback mechanisms that we had in place previously, so whether that's GP surgeries or access or patient information. So we have processes for information that we can utilise in what do we know and what impact has that had. There is just a national position that said, however, that we are being asked to operate in restricted financial envelopes, cut our running costs by 50%. It's unfortunately, it's a fact of where we're operating in, and my position won't be any different to any of the 11 ICBs within the region. So we're working in policy, national policy, but we will continue to collect feedback, but also work in an impact-assessed way. Thanks.
Andrew.
Yeah, thank you, Chair. I've been resisting asking questions because I know we've got a set-out framework of thematic sessions, including the one about staffing. I think that's number 2 on the workforce one. So I just wanted to check that how we are approaching it like that, aren't we, in terms of we're going to have, there's 9 themes here, and we're going to do one of those at every single meeting, or is that going to be enough time to get through that? Because clearly, you've heard from tonight, there's people we want answers as soon as we can on some of these issues. So be guided by you, Chair, and how we're going to approach that. Can I also ask that if you could circulate your slides as well afterwards, that'd be really helpful, I think, for us.
No problem.
Thanks, Chair.
Through you, Chair. There's a couple of questions per category, so we'll get through a couple at a time. My point at the end of this was going to be, do we want to meet informally sometime in July and order these categories into an order that works for us, given that financial sustainability and system risk could be something that's relevant around the budget setting period, but that's currently number one on the list. So did we want to look at developer contributions, for example, as a first priority, given that we're in the Regulation 19 local plan? So we can rearrange this list as we see fit, and then if we were to gather informally in July and go through that, I can then send those questions to Maria, who's then got 2 months to research the answers and bring those to the September committee, if everybody's happy with that. Chair?
Good approach, Chair, I'd say.
Yeah. Are you happy with that, Maria?
Yeah, more than happy. I think that meeting is helpful to reset that. I guess my only response to it would be we do feel like we're live in change, and councillors' comments around some of that could change very rapidly as well.
Right. Thank you. Well, thank you for coming this evening, and thank you for providing us with the context. I think this is the beginning of a programme of work. I think we need to make sure that as a committee we join up across the local authority. Hayley can bring in things from children's side of things, so that we just have that kind of set. There are also, as we were saying, place implications, so we need to make sure our place colleagues are involved in it as well. So thank you very much, and safe journey however far you're going.
If it's okay, Chair,
Yeah.
I'm going to sit and listen. Thank you, colleagues, to the St Andrews conversation. I'm just mindful from an ICB, there might be some questions from me, and I'll leave then.
Yes, that's very good. Thank you. Thank you very much for your input. Are we okay with our conclusion to that, Richard? Good. So welcome David Williams from the Northamptonshire. Whichever. Tell us your organisation, and thank you for your briefing note to us. I think it will be useful if you can give us a bit of context and a bit of history, just to bring all the committee up to speed as to what has, in a way, a sequential account of how we've got to where we are now, and we will just listen with interest to what you have to say to us.
Thank you. That's lovely. Thank you very much, Chair. David Williams. I'm Director of Strategy and Partnerships for Northamptonshire Healthcare Foundation Trust, so community and mental health trust provider here in the county. So we wanted to come along today to give you a chance for a bit of a briefing about where we are with St Andrews, some of the things going through, and just to aid some understanding, because very much aware that there are lots of different kind of information and things that's happening. So there have been some historic issues, and on the 9th of March this year, NHS England made a decision that all NHS commissioners should be identifying alternative placements for the 287 patients who were there at St Andrews. The decision wasn't made lightly, and it's worth really thinking about looking after both the safety of those patients, but also the complexity of their needs and how they would need to be looked after. So during March and April, a process of thinking about how to implement a plan and a different way of working and where the opportunities were was looked at. And in the course of that, there was an opportunity to review and revisit what that plan was. And early at the beginning of May, NHS England identified and shared information that an alternative would be that rather than to have St Andrews as the provider of the Northamptonshire buildings, it may be preferable to see if an NHS provider would step in and take over some of those buildings and provide the care to those patients here in Northampton. There is so I'll talk through the patient safety, the quality side of stuff, but it's probably also worth thinking that St Andrews does employ a large number of people. Many of them are local. St Andrews is also a provider of one service, which is medium secure deaf service, which is the only provider in the country for that service. And then it's also only one of 2 or 3 providers for men who need medium secure hospital care and have an acquired brain injury. So we would be looking at a loss of employment, a loss of changes of ways of working, and also a loss of specialist skills. So one of the alternatives that NHS England had suggested was that there was the potential for an NHS provider to step in and take through and see whether those services could be provided safely here in Northampton. So currently, the organisation I work for, so NHFT, is undertaking a piece of due diligence to understand whether we feel that we can safely step in to provide that care. And we will look at all the things that are involved with that and working it through and come to make a board decision on the 30th of June. And then that, if we decided that we thought we could do that safely, that would enable the ability to step in at a date to be agreed in the future. But that would mean that the care for many, but not all of the people who are currently in care, would continue in Northampton. And that would then enable continuity, ways of working, employment, and opportunities from there. But really important to say, so we're currently going through the due diligence. We're currently working through where we are. I was talking to Councillor Purser earlier today just to work things through. I cannot tell you what the outcome of our board decision will be, and I can be really and absolutely honest with you that we haven't written the final recommendation for our board at this point, so we're bringing everything together to understand, and that decision will be based on, can we provide and do we believe we can provide the care safely on day one? And can we transform and develop and deliver the service so that it's safe for all of the days moving forward from that? But it's an opportunity that I suppose is twofold interest for this committee. One of which is, can we provide safe care to people who've probably known Northampton for quite a long time? But also, in doing so, that has the potential to provide some more sustainable employment and support to people. So we thought helpful to come here at this point to give you a briefing.
Councillor Herring.
I gather it's a very large site. Is it owned by the NHS at the moment, and would that ownership transfer if you decided to step in?
So the site isn't owned, it's owned by St Andrews Healthcare. So anything that they would want to do would be a lease agreement or something like that. So we are in the process of exploring all of those different types of options with them. But they're, yeah.
And would you, are the buildings fit for purpose, or is that part of the trouble? And would you have to redevelop?
So their buildings have got a range of times that they were constructed in and ways of working, but 2 of the buildings nearest, I think it's Billing Road, nearest the Northampton General Hospital, are modern buildings built to modern specifications, so they look to be in a good state of repair.
Councillor Owens.
Yeah, thank you, Chair. I think we all agree St Andrews is a very important part of Northamptonshire and has been around for over a century. And, you know, to lose it would be, like you said, David, a really, really important and detrimental impact to Northamptonshire. And I think it's really good that the Trust is volunteering to try and move in and try and save people's jobs, basically. And I think that, from my point of view, I think my concern is, and I'm sure you've already understood this, is that something went wrong at St Andrews. And I think you could almost say 10 years ago, there were kind of like mutterings around people within Northamptonshire that there were issues going on within St Andrews. And nothing was done at the time. It was ignored by the managers and the directors of St Andrews, and it was let to go to the state it is today. And the fact that you've come in and you're willing to take it on is really, really good. But how are we going to get round the issues of patient care? Because there were severe failings with serious assaults against patients, and I believe including rapes. Several rapes were taken place in there with the staff that were in there at the moment. Now, those staff may have been identified, but I would suggest that there's more than that. There would have been a culture of abuse that had manifested itself in St Andrews and affected directly many patients within St Andrews. So if you're going to take it on, my two concerns would be, one, how are you going to make sure that that culture, particularly amongst the staff that will remain, it would be driven out to its core so that we can make sure that the patients in Northamptonshire are safe and they are looked after. Number two is, if you are talking about taking it over and there is going to be a change in staff, how is that staff going to be funded? And are you therefore going to say that you're going to be bringing in agency staff? Because I have a real problem with agency staff being brought into the NHS because they just don't have the same kind of like contracts as NHS-based staff. So normally NHS staff that are agency workers or bank staff, they just come in for the day and then they're gone. There's no continuity of care. And I would hope that you would try and avoid that reliance on a lot of agency and bank staff working there to compensate for the changes in staff. That would be my question to yourself, David. Thank you.
Thank you, Councillor Owens. There's a lot to unpack, so let me just talk through right at the very beginning about culture and organisational development. So absolutely the culture needs to change, and a lot of our due diligence has been spent understanding what it's like there, and if you want a way to describe things, this is how people do work around there. And really sit there and ask ourselves, do we think we can make a difference and can we change it and can work it through? Because if we don't think we can change the culture, then we're not going to be able to make sure that patients are safe, and therefore, you know, it would be better not to do it. So we have spent a long time looking at what do we need to do differently, how we would invest in culture, how we would change the organisational development way of working. And we're sitting here at the moment really looking at what does that mean and where do we go? So we would invest an awful lot more into culture and OD, into understanding and ways of working. We've been also, it's complicated because to change a culture, it needs to be everybody's job. So I'm slightly wary about saying, should we decide to do it, we'd increase an organisational development team and a way of working, because just a couple of extra people isn't about how we solve it. It's about the way everybody comes to work. It's the way we do stuff around here. So it is absolutely a big focus. I've worked for a number of different NHS organisations, and I guess one of the reasons for staying in NHFT for a long time is that I really do like its values. And I do see the way that it champions and challenges stuff. So I sit here at the moment going, you're absolutely correct. How do we make sure this never ever happens again? And it's a focus that we've got. And the board decision would be, can we do this? And if we can't, the board would say no. So I think that touches, I've got a little note here down here. I was going to talk about our values and behaviours, but I think potentially I've kind of tried to show that. Agency staff use at St Andrews is very low. Very, very low. So it's not our plan to increase it or to move it about. It's a focus about the people who are doing the work there today and making sure that that work is of good quality and people understand why they're doing it.
I think Councillor Chauhan.
Yeah, I was just going to ask a question. The last time you came, we spoke about waiting lists. And I think at the time it was around about 52 weeks for, I think, CAMS, if I recall correctly. If you were to take on this service with St Andrews, what would be the impact on those waiting times, do you think?
So I think the simplest bit is there wouldn't be a change on any of our other services. So one of the really important bits we're working through as a board is the decision that says, how do we make sure that we continue to deliver well on services that we've got already? How do we continue to transform and improve them? And how do we take this on? And that'll be an important bit of what you don't want to do is to make one bit of the organisation work really, really well at the expense of another bit of the organisation. What we've got to do is to maintain and improve where we are at the moment. And then if we want to feel it's the right thing to do, step in and bring this one up as well. So it is a focus on making sure that it's everything and not a different one.
Alison, I think, next, and then Rosie.
Just as a question, and it may not be relevant to this moment, if you decide in the negative, how do you disperse? How do you deal with the issue?
So there's a very short answer to that, which is that would be NHS England's job. It wouldn't be our job. But that sort of hides away from the fact that the people that are in St Andrews needing care are really complex and have got really complicated behaviours. St Andrews does have a large number of buildings which are suitable for safely holding patients who need medium secure or low secure facilities. And so somebody would have to sit there and say, well, what was it that NHFT felt was unable to make it, and who else would be able to be there? So you could turn around and try and disperse people around the country, or you could use the buildings in a way that we felt we couldn't do. But it is the need to protect those individuals and the need to protect the public from those individuals is really, really paramount. So the building design is not easily replicable or cheap to suddenly build somewhere else.
The reason I asked the question is you may or may not be aware there's another institution in my ward that actually was under a similar problem, but we're only dealing with 22, actually 36, it depends how you look at it, patients that would have had to be dispersed somewhere else. And in fact, an organisation in Milton Keynes has now stepped in to take it on. Which is how I asked the question, because for a funny sort of way, they've been saved.
Yeah, Rosie, come in.
Yeah, I mean, given what we've heard today from the ICB and the funding, will you get direct funding, additional funding, if you do decide to take it on? And if so, do you think it's going to be enough?
So the commissioning arrangements for what the NHS describes as specialised services are slightly different to what we'll call general services. So for specialised services, because in a population area you only have a very few numbers of patients, but the care for them can be relatively expensive compared to other care, ICBs don't commission a large amount of this type of care. The deaf service is commissioned directly by NHS England, directly at the moment to St Andrews as being the only service in the country. And I think the medium secure acquired brain injury is commissioned from, I think there are 3 locations in England that deliver. It's 2 or 3 locations. So they're direct contracts from NHS England to St Andrews. And then there is a slightly different contracting mechanism which governs some of the other types of needs of medium and low secure people, and it's commissioned across the East Midlands. So your conversations with the ICB before about where it's going in, the ICB has a role around quality, safety, ways of working, but the amount of sort of funding for this is actually managed on a bigger pool because of the need and few people attend.
And when the board is faced with the decision, do they get that financial information as part of that decision-making process?
Oh, yeah, absolutely. So, I mean, as a way of, if you think about a decision our board needs to make, one of the ways of deciding whether you can safely provide a service is to know how much money you've got in order to think about how do you staff it, run it, manage it, and ways forward. So, understanding the income and understanding what that means in terms of service delivery are two that are marrying together to think that through.
So, is it just worth noting that the Charity Commission today announced that they're carrying out do they call it a statutory review of the governance of St Andrews? So that has been announced today. I think that's a significant move forward in looking at what has happened over this, well, whatever the period of time is. And I think there are some significant governance issues that I'm keen. Would you like to come in, Adrian? I've got some. I think we need to take some recommendations from our discussion today. But yes, come in, Adrian.
Yeah, thank you, Chair. Through you. Yeah, I have a few concerns of what I'm not sure I am understanding fully what I'm hearing. Is there an issue with the staff that are there? Because we're talking about protecting jobs and keeping the same employees. Is this normally when a business takes over another business, it's 2P transfer, transfer of undertakings, protection of employees. Are you forced to do the same thing, or with what may be issues, as I'm hearing tonight, do you now have the option to sort of delete staff that you don't want? And is that obviously part of your consideration? Because otherwise, all you've done is you've moved the management, the same people doing the same jobs with the different management over the top. And I understand that's probably one of the things you're concerned with. Thank you.
Yeah, absolutely. So, in principle, 2P applies. What we've been sitting there and working out is, so how much money have we got? What do we think is a safe model? How do we change the culture and the way of working? And if you want, there's what's happening there now, and a slightly separate conversation, which is, do we think we have a model? If we draw out on a blank sheet of paper, how would we deliver this safely? How would it work? And then you kind of match the two up, rather than just saying, oh, should we just move that over there and deliver that? So we've spent quite a bit of time sitting there going, what would we do in order to make this deliver safe? Of which there would be an element of 2P, and it might be a different structure and a way of working and an understanding, but we're not just going to lift, shift, carry on and think everything would be perfectly fine.
Yes, Alison.
If the Charity Commission is involved and arrives, will you have to work under or with their edict?
So we'd be in the position where we would have nothing to do with them at all. Their Charity Commission investigation would be into St Andrews. So as a completely separate provider, they would undertake whatever they would like as an investigation into St Andrews. Should we decide to step in, we would be a provider operating underneath the NHSE terms and conditions. The review would be very helpful to pick up learning and other understandings, again, about culture, the ways things are done around there. But whatever that finds, it doesn't directly impact on a sort of rules and principle to us.
So whatever I'm going to try and, so we're going to receive a report at our next meeting on the future plans. Whatever the Trust decides, we've got it on our agenda for the next meeting to receive a report on, very much, I suppose, focusing on the service and the patient care, looking into the future. So that we've got that on our agenda. I think I would say that given the needs of patients and the significant part of our local economy it is, we kind of welcome the initiatives that are taking place, and and we can't. I don't think we have any. I think the Trust Board must make its own decisions, but we've got an interest in good patient care and good employment in this area. I kind of think we should recognise the work that the NHS has put in. I had a briefing, and there's obviously been a significant amount of work put in by the NHS nationally to bring the situation under kind of the sort of remit of the NHS. Can we welcome the proposal in the briefing note, subject to the board's decision? I guess I would want to ask our cabinet to give every support to NHT should they take on the service, so that we would have a strong working partnership between the local authority and the trust. And I think one of our concerns has been that actually we've been that things have operated too much in isolation, and that we really need to build a strong partnership between the public health and the adult services and whoever the provider is in the future. And it might be that we just keep it as what in terms of future provision, that we are committed as a local authority to really support whatever the way forward is. And I think that should be a specific recommendation to our cabinet. And would that work for you, Laura, that we do that? Mm. So are we all in agreement with that? Yes. Yes. David, can we thank you very much for your time this evening and for your careful answering of questions, and for the work that is going on, and not only yourself, but that whole team. That I think we'd want to express our thanks to everyone who's been working to secure the future for the patients and for the future provision that goes on there. So thank you.
Thank you. I'll pass that on. Much appreciated.
The end of June, will there be a public announcement, and can we all be informed?
So after the decision made on the 30th of June, we need to align some communications with NHS England, St Andrews, ourselves, and probably a couple of other organisations. And so when does that come out needs to be just worked through of how it works. I can absolutely guarantee it won't come out on the 30th of June, because we don't start meeting until the end of the day, but absolutely we'll try and make sure. One of the key stakeholders, we've met with your interim CEO, we've met with a couple of directors, people are all talking things through. So, you know, once the decision is there and everybody understands where it is, that the information will be shared. Clearly, you've got to make sure NHFT staff know at the same time as St Andrews staff. NHS England needs to be involved, all of those things. And if it's a no, we're not stepping in, or a yes, we are, they have very different implications that all will need a bit of planning and management. But there would be a communication about it.
Thank you very much. Yes, thank you. That's much appreciated. Right. Right, I think we are moving on. How are we doing for time, Richard?
Half an hour till the car park closes.
We've got half an hour till the car park closes. Right, and do we have the technology to get out of the car park? Michael, come and introduce yourself and present your strategy, and hopefully we've got some questions for it. Yes.
Okay, so I'm...
Oh, yes, of course, yes. Do you want to do your presentation and then speak, or would you like to speak first? I'd like to speak first. Right, okay. Would you like to just give... Yes, no.
Press it.
Yes.
I just want to say,
yeah.
Richard sent me the PDF for me to go and get it at the library, because I don't have a printer.
Yes, the minutes of the meeting, yes.
I got the minutes of the previous meeting because a lady done it for me. I also went to the library on Friday and there was a different person there and he said he couldn't do it. So I had to go over to the Photoshop and get it done. Normally, they charge for it, but because I go there regularly, she didn't charge me. And also, with digital services, older people cannot get digital, especially within the NHS as well. Doctor's appointments, digital, everywhere is digital for older care people. That's all I wanted to say.
I think that's a very timely reminder that digital services are only useful if you can use them, and we need the whole population trained up.
People to have phone numbers.
Yes.
Especially for councillors.
Yeah.
They can't get hold of them.
Yeah.
Sorry.
Right. Oh, Michael, over to you.
Hello, I'm Michael Hurt. I'm one of the heads of service and strategic commissioning, and I can introduce one of our new colleagues.
Hello, I'm Lisa Mullin. I'm the new Director of Operations for Adult Social Care.
Right. Welcome.
Thank you.
So in the interest of time, shall I just do a brief overview and then you can ask questions?
Yes.
Okay, so essentially what we want to do is move to a tech-first approach. So when we do our assessments with people, we consider technology that might support those people right from the start. We know at the moment, excluding Lifeline, it's about 20% of people. Other councils are moving with targets of 70 to 80%. We know that if we use tech, it can save on hands-on hours, and also some people don't like the intrusion. People come into their home, which we know when staffing issues are difficult, we have bad weather, you can get a different person each time. People don't, a lot of people like services first thing in the morning, and providers can't always do that. So there are a range of benefits for that. As tech comes out, it's very hard to keep up with. So some of the things we're doing, for example, is a self-assessment service we'll do through our Millbrook provider, which has been demoed in a couple of days at the university. And there'll be a series of questionnaires. So, for example, if I don't know much about dementia, I'm looking after somebody, I can answer all the questions, and that would then point me towards some tech and where to get it from that I might want to get myself or through the service. Our assistive technology team currently provide tech for people, and we know that where the stuff's free, there's quite a good uptake of that. And you'll see from the case studies in the strategy that people are finding it very helpful. And half of it with our staff and with people who haven't used it before is knowing what it can do for you. And so that's why a lot of the emphasis on getting that message out there, that it can help people. When it goes to Cabinet next month, there is also a financial model that goes with it that shows really that we will need to invest in some more assisted technology staff, because of course we have to people to go out and demo it and give it out, but also some commissioning time because it's a 5-year strategy. But even with that, and even if we offer more free stuff than we do now, which is what we're proposing, over the course of the strategy, our finance people reckon it would be about a kind of £1 million saving. And we try not to be too optimistic, because I know with other councils that we've spoken to, they start off with targets, we're going to save this much, and each year it comes down a little bit as they get more realistic. So we try to be more realistic from the start. One of the problems we've had is that we've got a system that, at the moment, if a social worker increases care or gives tech, it's not always recorded that tech's been given instead of that, so we need to improve our kind of recordings. But that's where we see it, as commissioners see it as a benefit for everyone, and something we probably should have done sooner, really, that we're getting to now.
Right. Tony.
Yeah, thank you, Chair. Actually, look, I'm all in favour of tech. I think it's a great step forward, it's a great advancement, and it can really help improve people's health. Certainly having that technology, the instant diagnostic kind of like tools there, particularly with like things like blood pressure, heart rate, oxygen levels, are great. My only concern is, and it's a concern as a medical professional as well, is that tech is great. Diagnostic, having all the readings there are great, but it's having someone being able to interpret those diagnostic figures, and also sometimes people can be, how do I put it, hemostatically, they can be stable, but actually they can be acutely unwell, because there's a stage before their observations are out of normal limits where they are basically still able to maintain their observations. So you can have people that are septic, you can have people with life-threatening conditions, but their diagnostic figures are still normal. And I would urge just caution that when you're introducing this equipment, that you always go back to the NHS's model for this tech. In fact, there's things like the remote model for consultations with clinicians via the telephone, that there's always safeguards there in place that you don't get maybe people that are less qualified or not with medical registrations or anything like that to interpret those figures and think that the patient is well because they may not be well, and always to have it like, how do I put it? Always to have a kind of like risk-averse behaviour within that tech, that if there's any query whatsoever, that they are forwarded to NHS medically qualified people at every opportunity. That's what I'd like to say.
Yeah, so I suppose I'd say that a lot of the equipment you're suggesting is used by the NHS colleagues already in terms of diabetes, blood sugars, and that's reported electronically. Ours is specifically around adult social care. So, for example, if it's somebody living with dementia, there is equipment that can prevent them turning the heating off in the middle of winter. That if the sink floods, there's a detector. If they go to leave the home, a detector will say, "Dad, don't go out today." That's been pre-recorded by their family. Or if he does go out, they'll have some sort of GPS sensor that's been agreed to and consented that will tell the family, okay, this sensor shows when they go to the shops where they've always gone, it's fine, but if they go outside of that boundary, it will alert people. So that's the kind of stuff that we're looking at. Reminders to take tablets if they're crucial for Parkinson's at certain times. But there's so much more than we use now that we could be using. That's what we're looking at, and more free stuff as well. But also point to people that can access to benefits that might want to buy their own, so to get that quickly.
Rich, Andrew.
Thank you.
I'm getting to that stage of the evening.
Thanks, Dave. I think it's a really interesting document, and I was looking at the tech that you say you're currently using. That looks a bit old-fashioned, to be quite honest, when you look at some of the stuff there. But you obviously do mention later on the new technology. And I think, as was illustrated by the lady earlier, I mean, there's a lot of people are very scared when you talk about digitalisation, and it's got to be personalisation. Sure, it's got to be about people orientation. And it's technology that means that you can still connect with people. So really interesting to see how you think that will move it forward. But also when you look at some of the stuff that you're using now and some of the stuff that's that's out there now, when you've got key safes, for example, where you can obviously now do digital fingerprint access, face recognition. That, in many respects, should make it easier, I think, for people to be able to do things that they might find difficult, like remembering what the key number is and all that sort of stuff. So, be interested to see how that moves forward.
Yeah, I think, and we say in the strategy that it's important that we promote independence and not dependence. And some tech cannot be helpful. I've seen examples of that over the years.
So can I just, sorry, yes, Rosie, coming.
How much of the adult social care budget is allocated to tech?
In short, I don't know offhand. Therapies deal with assistive technology at the moment. I think that will be in the finance appendix. It shows what the current cost is. And what we've done is looked at, because we haven't got brilliant data, we've looked at the average cost of a care package where we've given tech to people, those people that are used as the case studies, and then we've looked at the average cost of care without tech, which is more expensive, and it shows in the paper, the cabinet paper, you'll see there's a difference of something like £300 and £400 or £500. And of course, tech you tend to buy once, initially it might need updating a year or two. Care is every year for somebody, as long as they need it.
Does any of it require the household to have broadband?
There's a range, because some of it will be working with, some of it doesn't work with any kind of Wi-Fi at all. Some can be worked through a 4G phone, depends on where you live, and others might be broadband, yes. And
because obviously a lot of the people you'll be dealing with won't have that facility and can't afford it. So this budget would also be paying for that?
Well, things like connection is what you'd need to look at as part of that assessment, but I suppose I want to stress not everything's related to internet, and a lot of the devices you can have in people's home don't require any connectivity at all.
I'm really interested in how the local authority identifies the funding for this and plans the funding of this forward, because as I think when we inherited from our predecessor authorities, investment in IT was very poor. And I think although we're 4 years on, I'm not sure within the adult services bit we've moved forward a lot. So I think to actually have a very clear idea of how much we're spending and how much we're planning to invest in the future is really important.
Yeah, so we've got costs on what's spent with our assisted otology team time, and we know that you'll know from our budgets and things the cost of adult social care,
Yes.
more and more people living longer but with sometimes disability, is going up and up and up and up. And cost of care is difficult, but also getting carers is a problem, and that's getting more of a problem. What this is doing is looking at alternatives besides always putting more hands on care.
Yeah,
So
and what I'm keen is that we as a local authority actually get clear what the budget for that is, both in terms of, I presume, the staff bit of it, but also the tech bit of
that's
it.
That's in the appendix B of the cabinet paper. It sorts out what we're proposing to spend on the equipment going forward over the next 5 years, and of course gradually winding up. What the staffing costs will be, because we'll need to employ more staff as we go along, not right at the beginning, and then overall what we will save, having done all of that.
Then I'm quite sorry, Rosie, come in. Yes.
Well, sorry, I hadn't finished, and you went straight in because I was going to say that I had personal experience because and this was from the county council, when I was caring for my father, they gave us an iPad type device that was supposed to tell him what day it was and whether he'd had his tablet and what time it was when the carer was coming in and things. He couldn't get on with it, and I am ashamed to say we just sat on it, and when he died we put it back in a box and gave it back. That illustration is saying you can't just have the tech without the people. There's no point handing it to people with a box and instructions and then expecting, everything to be fine. You need the backup, and especially with the people that you're dealing with who are possibly elderly, possibly disabled, possibly handicapped, with dementia and so on. You've got to have the staffing backup to make sure it's being used properly and is truly useful. And that actually just didn't happen. And it was handed out. Wonderful, great, how exciting. And it just sat in a box.
Yeah, so part of the strategy, as well as the additional assistive technology team that we need to grow, is around changing workforce culture, working with our social workers, and part of the assessment how it might benefit people and those people receiving it and their carers. Because as you're right, there's no point in giving anything if no one's going to use it.
Or even understand.
Yes.
It's all right, don't worry. I've just been through the saga personally, rather like Rosie. However, the element of it is you may have the people, you may have the equipment. It's the time that you are prepared to spend initiating it into somebody's new life to make sure that it can be used properly to your advantage and to theirs. It's no good just chucking the box at it and say, get on with it. The answer is most of us have not a clue. And when they're dealing with people who are either at end of life or blind or handicapped, is that there is a human element that has to be engaged with. And I'm sure that you've taken this on board. But all I can do is just to endorse it.
Yeah, and remember, a lot of these people will be having care hours as well as from carers. So part of our strategy is working with providers on what, for example, we have care home forums that, with the team and commissioners I work with, and home care forums. We're showing them tech that will benefit those people in their areas. So
I
what
hate
it's
to
doing
tell
is
you, you should see what we had to go through until two of them threw up their hand in horror and said, I don't know, get on with it yourself.
All right, okay.
Worth remembering.
You're probably getting the same echo from all of us in here, because we're all in a place where we're looking after elderly people. And one of the biggest issues that I've just recently had with my 92-year-old father-in-law is that every supplier is going digital. So everything that you currently haven't been dealing with has to then convert across the digital side. And in the end, I'm very tech savvy, and I gave up with them. So we actually got rid of it all. So I can find myself around everything, but in the end, dealing with our suppliers who said, well, you have to go digital, we have to do this, in the end, we just took it all out. So it is, it's a tricky subject.
We don't have any choice in the digital bit, do we?
No, we don't. But I mean, it's something that they're forcing on us, so you have no choice but go down the digital route, even for a standard telephone that which elderly people still want. So it's just worth taking into note that everything that I've read in this report is fine, but a lot of it on the digital side, I've just recently found an absolute nightmare. So we've taken it all out.
So do we have preferred suppliers locally for these services?
We have some providers we actually work with. So, for example, a system we use a lot around assessing people is known as the Canary system. That's just been updated, so we're looking at them. So we do use a lot of those, yeah. But what we need to do is we're kind of meeting people all the time. So, for example, next month, Richard Beard, who works with tech, has got a demo of some robots that we use for personal care and loneliness, as well as reminders and all those things. So we're always looking for what's coming next.
And MPH have been doing this for some while. Do we have? Is what you're doing linking into the support that MPH provides for many of its tenants?
I don't know about that.
Right. I think that might be an action point that we want to not lose. Hayley, come in. How are we doing for time, Richard?
It's 18 minutes past.
Right. Okay.
Thank you, Chair. Just a couple of quick questions. The first one is, how are we going to mitigate risk of tech going wrong? And the second one is the lifespan. I appreciate that technology is always moving on and you're always thinking of the next thing. It never sits still. Thank you.
Yeah, so as far as it going wrong, we research what equipment we get. We don't just wait for the first salesman to knock on the door, and I would think we're quite thorough about that. And if other councils are benefited, so I'm, for example, meet with all the other East Midlands commissioners around other themes. So we do meet with them and what's good, and sometimes equipment's recommended by people like through the LJ and ADAS. We're in regional groups with ADAS as well. But sometimes these things happen. And in terms of lifespan, some things will go out of date and need to be replaced, but it still works out. More cost-effective model in keeping people independent. It helps with preventing crisis as well, and ultimately can keep people out of care homes longer and to be at home where most people want to be.
And my final question, I think, is about monitoring and how we... Where does that happen? And because in the strategy, I think there might be 30 different bits of monitoring to go on. I suppose I'm particularly interested in how we as the Scrutiny Committee have a role in monitoring how well this strategy is doing over time, and how we do that really. Is it fed into our data reports that we get?
So yes, it can. So it can do. So the implementation plan will give more specific targets for things. There's the obvious ones about cost of care hours versus tech and keeping people out of care and that sort of thing, more independent at home. But yes, and last time I took a strategist cabinet, they wanted it reporting to Health and Wellbeing Board annually. I don't know if they'll want that this time. But there's no reason why we can't bring reports here as we do now as part, because I manage the quality team, for example, that brings reports here too. So we can do that with that too. And either you can say as a committee what you want reporting back on, or we can make suggestions and you agree them or not.
Excellent. So I think I'd like the 3 recommendations, but I think I certainly would want to say that Cabinet should have a very clear budget, an allocated budget for this, or identified budget for this. I think the second thing is about monitoring, that we come up with a proper monitoring structure so we see how it's going. The third thing is about making sure that we make links with NPH, yes. And I suppose there is this thing about how do we keep people at the centre of this, isn't there? There is something about it needs to be person-centred rather than machine-centred.
Yeah, so one thing that we do with our DMT managers meeting is that we have a case study once a month of how what we've done has improved someone's life, and that's from there. With Northamptonshire Carers, for example, we record podcasts of them, so we can always provide one of those periodically if you'd like.
Yeah, it's same with buildings, that the architects get into things before people have worked out what to do with it. And there is something here about we can be seduced by the technology where actually it's the people that are important to what it's. So that maybe that I'd want that to be recommended. I think time's going on. Can we thank you very much for your input this evening? Thank you for writing the strategy. Really important area of work, really opportunities for us. I think we're really interested in this, and commend it to Cabinet with those, I think, 4 comments, unless anyone's got another comment they want to add into it. Is that okay? Can I thank everyone for their attendance this evening? What have I got to do? Oh, we're not finished yet, people. We're not finished. Item 9, draft committee. Richard is going to report on the programme of work, which he's going to do in 2 minutes. Thank you for your attendance.
Thank you, Chair.
Yes, apologies.
That's okay. I'll take the committee work programme as read, but I've put this together to reflect the discussion we had in May. The committee work programme runs to the end of the calendar year rather than the end of the municipal year. And as Councillor Simpson put it last time, we're moving from overview into scrutiny this year. I'll update the committee work programme with the ICB meetings programmed in, but I commend the work programme to you, Chair, for approval.
Right, and there was just one thing that we had the 3 scrutiny committees meeting last week. And certainly we raised the issue of the work with the local area partnerships. And I think the view is that we'll work with our partners towards some sort of workshop session on that, so that we actually look at the lapse with all the partners who need to be involved in that. So that's the way we're heading with that. Was there anything else I needed to pick up?
No, thanks. Chair, that's in the work programme as to be confirmed. So as soon as we have an update on that, we will update the work programme.
Can we agree the work programme then? Otherwise, you're not going home. Fortunately, I have no urgent business, so now I can thank you for your attendance. Thank Richard for all his work, and see you on the 1st of September for the next meeting. Oh, right, okay. We'll note that.
I'll record them now for you. Also, I'm Christine. I was going to say it's Christine.
Right, okay. Yeah.